Um, just so that we are sort of in the planning process for next year. So if you have ideas or speakers or great people that you know who would be good for this series, please reach out to me, London Breedlove, or others in the committee. We'll be taking questions at the end via chat and also in person, but we hope to get to as many questions as possible, and we'll try to answer all that come through as best we can. And with that, I'm going to introduce our speakers. Speaking on transforming primary care practice through research approaches from the WWAMI Region Practice and Research Network. We have Dr. Sebastian Tong, Assistant Professor of Family Medicine, and is a practicing family physician and addiction medicine specialist, Assistant Professor in Family Medicine at the University of Washington, also serves as the Associate Director of the WWAMI Region Practice and Research Network. He conducts research in practice-based research, substance use, loneliness, chronic pain, and has received funding from the NIH and Agency for Healthcare Research and Quality. He is one of the National Academy of Medicine's 2023-2025 James C. Puffer American Board of Family Medicine Fellows. Medical school at Boston University, and a Master of Public Health from Harvard School of Public Health. And also joining us is Dr. Allison Cole, Professor of Family Medicine. Allison Cole is a family physician and researcher at the University of Washington School of Medicine. She earned her MD in 2002 at the University of Iowa and completed residency training in family medicine at the University of Iowa Hospitals and Clinics in 2005. She was an NRSA fellow at the University of Washington and earned an MPH in Health Services in 2012. She's director of the WWAMI Region Practice and Research Network and studies implementation of evidence-based program in primary care setting. Her research programs focus on cancer control and screening interventions and rural health equity. So welcome to our speakers today. Thank you so much.
Thank you so much. Thank you everyone for joining us. And I'm glad for the in-room experience that we stopped having the live lawnmower for now. For the in-room experience, we also have kisses that are WPRN labeled if anyone wants them as well. So feel free to take some of those. So Allison and I are here to talk today about kind of some of the research we do in our department and specifically focus on practice-based research and how we are hoping to transform and continue to transform primary care practice through the research we do across our 5-state WWAMI region. So we're going to run through 3 different objectives describing kind of some strategies we use, informing research priorities, and also looking at methods that we use as well. And we'll give some examples. We have no conflicts of interest. We have some funding disclosures. So the roadmap for today, what we're going to do over the next hour is describe briefly what a practice-based research network is and why it matters to practicing family physicians. Talk about our WWAMI Region Practice and Research Network, and also talk about a recent growth opportunity that we're engaging in called Care for Health from the NIH. We're going to talk about 3 different examples of studies that have been conducted in our region. One around loneliness, one around a rural health initiative, and one around quality improvement around aging. And then we're going to talk finally about opportunities for collaboration and growth. So to start with, I think many of you may have seen this, but why do we do practice research-based research? It's because most of healthcare happens within the primary care-based setting. So this is a graph that was published in New England Journal of Medicine back a number of years ago. So basically what it's saying is of a typical 1,000 people in the US population, in any given year, 800 of them experience some symptoms of something that you might consider seeking medical care for. And then 327 of them consider actually going to seek medical care. And then 217 actually end up in a medical care setting where they're seeking medical care of some sort. And of those, 113 of those go and get care in a primary care office. So what we're seeing, without going further in, is that the majority of medical care actually happens in an office-based setting or in a primary care setting. And if you go all the way down in, only 8 people are actually hospitalized a year out of the 1,000 people. And of those 8 people, of those 1,000 people, less than 1 in 1,000 are admitted and hospitalized in an academic medical center. So we're seeing, even though the majority of research happens in large academic medical centers, that's really less than 1% of the population. Now we're going to take that and flip it and look at where NIH dollars go. And that has been in the news recently, right? So I think that's something we're working on through practice-based research networks. So when we look at all the dollars that go into research from the NIH level, the orange on the pie chart is supposed to be primary care research. Most of us can't actually see the orange because it's so small. It's actually 0.2% of dollars go into primary care research, and the other 99.8% go into other research and other non-primary care focused research. Another way to think about it is, I think the Robert Graham Center published an article showing that actually more research dollars go into ALS than into primary care. So about I think in 2022, only $108 million went to primary care research, but $200 million went and were dedicated to ALS research, which is a medical condition that I think few of us actually take care of or see. I think last time I really thought about it was in medical school, and I know there are people with it, but it's not taken care of in the primary care setting usually. So what is the Practice-Based Research Network? It's a group of ambulatory practices that come together and do research. We have, in our network, practices across the WWAMI region. It's those who are affiliated with investigators and kind of have questions they bring to community-based practice and look at how we implement evidence within practice-based settings. This was a commentary published in JAMA back in 2007 saying practice-based research is kind of looking at what used to be the blue highways, so not the main highways or the interstate highways, but looking at where research happens on the small roads in the communities, getting to know communities and making things that are relevant to communities and to primary care practices happen. So what is our network? Our network is the WWAMI Region Practice and Research Network. It's a collaborative group of about 140 practices across our WWAMI region that are committed to participating in research and quality improvement together. This is kind of a map. We have actually, since we made this map, some had growth as well. This represents health systems rather than individual practices in our network. So as you can see, we have academic practices like UWPC. We have FQHCs, we have non-academic health systems, we have tribal clinics, rural health clinics, some independently owned practices still, and then one naturopathic clinic as well, actually. So our mission is to improve the health and well-being of patients in communities through the conduct of collaborative research, really focusing on the collaborative part where we're taking back information from individual clinicians, practice leaders, patients, and using that to inform the type of research that we do. And we really hope that the experience for clinicians and for researchers is really one of that's bidirectional in nature and not just like investigators coming to practices doing research. And we support practice innovation, we support quality improvement efforts, and really try to focus as best we can on conducting research that matters to practices. One of the ways we do that is by having a regular monthly steering committee meeting, and that actually took place earlier this morning. So we meet virtually once a month, and we get practice feedback from practice leaders, practicing behavioral health providers, pharmacists, residency leadership from across the WWAMI region. Right now, we have 4 or 5 of our WWAMI states represented on our steering committee. And they not only provide kind of high-level kind of research priorities on what we do and focus on as a network, but they also approve every single study that we do. So no study goes forward without their approval. Other engagement opportunities, we have an annual meeting in June, usually in Seattle, where people have a posted session and get feedback from practice champions on their ideas. There's a collaborative session where brief initial ideas are workshopped together with practice leaders, and then also larger group discussions and informal networking. We also have for maybe clinicians who want to do research, but their practice isn't able to do research, or if their practice even is, but they want to do small scale research, we have what we call a provider panel for research, with issues about 4 to 5 surveys or invitations for interviews a year. And that's for researchers who want to get initial feedback for study ideas, or maybe just do a qualitative study or do a cross-sectional survey type study. So this is some examples of studies we've done in the past year. They really range across the board from all different types of topics, from patient-provider interactions to pain management to firearm prevention to ADHD to cancer survivorship. And some of these have led to funded NIH proposals or to actual funded grants that lead on to future work as well. Other engagement opportunities, we try to get out into the community and talk to providers on an ongoing basis. Allison was actually up in Alaska over the weekend to talk at the Alaska Academy of Family Physicians. We do a lot of community and site visits, and we do local needs assessments as well. So the range of research that happens within the WPN ranges from things that are pragmatic clinical trials, like implementing integrated behavioral health into practices, and how do we find and which are the best models, to one that we're doing right now is testing whether antibiotics are effective for sinusitis in primary care. And we kind of all think we know that, right? But like, there's actually no evidence in primary care settings, so there's a large scale pragmatic trial that's going on right now. To implementation research. So how do we support improving colorectal cancer screening in primary care practices, or implementing planning guides for implementation? And then there are a lot of observational studies that happen as well with EHR data, with survey data, and with kind of interview data with patients and clinicians. So I'm going to have Allison talk next about.
Great, thank you. I'm hoping that you all can hear me, or will give me a signal if you can't. So I'm going to talk about a new partnership that the WPRN has been part of that's really exciting. It's called the Care for Health Award, and this was announced initially in September of 2024. Dr. Bertagnoli, who was the NIH director at the time, really spent a lot of time investing in developing a program that could support engagement and partnership with particularly rural primary care practices, and had a vision for developing this infrastructure and then growing it and sustaining it over time to help increase the access to research in primary care settings, but also to help ensure that NIH-funded research actually addresses critical questions from primary care and designs and tests interventions that are relevant to primary care. So go to the next slide. So this is an overview of the larger NIH Care for Health program, where they're really focused on developing this infrastructure and using that infrastructure to co-design research studies that will then be funded by NIH. Co-design happens at the center level between primary care practices and research teams, and then they get funded through the NIH to help facilitate real-world important research and adoption of evidence-based research findings. So right now we're in the first year of a 2-year pilot phase, but the intention is for this program to be long-lasting and durable. Go to the next slide. Let's see. So again, this is just a little bit more about the infrastructure from the NIH side, and I think the details are less important than just the recognition of how transformative this initiative is compared to how funding usually comes from NIH. And I think Sebastian talked about how the vast majority of NIH funding goes to specialty-based research rather than primary care-based research. So this is a very different type of investment and a different type of focus. And it's really the first time that we've seen this kind of initiative where the goal is not to address a specific disease or condition, but instead to really understand the community and the context of primary care, and allow primary care and encourage and support primary care to to tell researchers what should be done. Go to the next slide. So we were part of the first 3 hubs that were selected for funding, and we're working with Oregon Health and Science University, OHSU, and their practice-based research network. And then University of Wisconsin and West Virginia University were funded on the first cycle. And then recently they expanded to include 3 additional sites in Oklahoma, New Mexico, and Alabama. Go to the next slide. So again, this is currently set up as a 2-year pilot, but the intention is that it will be long lasting and durable. And the first year is really focused on building the infrastructure and demonstrating the success of it by implementing some existing studies in partnership with primary care, and then eliciting clinical questions and priorities from primary care and community, and translating those into study concepts that then will be taken to NIH for consideration of funding. And go to the next slide. So our specific hub is called Practice, the Primary Care Rural and Frontier Clinical Trials Innovation Center. And again, it's a partnership with the Oregon Rural Practice and Research Network and the WPRN. And both our networks are supported by our CTSA programs here at the University of Washington. That's the Institute of Translational Health Sciences. So why might practices and why was the WPRN interested in being part of Care for Health? Well, we recognize that patients who are seen in primary care are very underrepresented in clinical research, and Sebastian showed that ecology of medical care and how researchers often recruit from academic medical centers, but most patients are getting care in other settings. And this really limits the generalizability of research findings. Go to the next slide. So this is a map of the partnership that includes Oregon and then the WPRN sites as well. And you can see Oregon has a number of rural primary care practices that are part of their network as well. And go to the next slide. So over the first year, we're really focused on building infrastructure to support engagement. And we think of this as extending across a continuum of community engagement, where the sort of early stages might start with outreach, where people travel around the region, like our visit to Alaska or other parts of the region, and just talk and meet with people and do outreach. And over time, as we develop those relationships and partnerships, we'll actually begin collaborating with our practice partners to co-design studies and implement them. Go to the next slide. So another example of research in the WPRN that I want to talk about is the ITHS's Rural Health Initiative. And this is a 5-year project. We're in the 3rd year of it. And the focus of this was really on ensuring that translational research, or clinical and translational research, can address the critical health priorities of rural communities. And there's been a lot of reporting to show that rural communities are often not included when health research topics are selected or research studies are designed. Rural populations are not often included in actual research participation, and dissemination and implementation efforts may not reach rural populations either. So this was a partnership with North Central Idaho. You can see the region circled on the map there. It's a 3-county area that includes Clearwater, Lewis, and Idaho counties. They have a collective population of about 29,000 in a geographic area that's larger than the size of Massachusetts. About 16% of people in this area live below the federal poverty line. About a quarter are older, age 65 or older. And one of the public health priorities that's really important to them is the high rate of suicide completion that they experience. Their rate of suicide is 3.5 times the national average. And they're also experiencing significant and ongoing impact of COVID-19 on their health systems and staffing. Go to the next slide. So we started this project with a community needs assessment. And the goal of this was to partner with local health system leaders and local community leaders to try to understand what health topics would be important for research to address. So first, we reviewed local, state, and national data to identify health areas where there were disparities for the communities that we were working with in comparison to either the state or the nation, and then selected 4 potential health priorities to present to community leaders. We then co-hosted with our team in CAMI Idaho, an in-person event with 13 community leaders. And the goal of this was to really assess the strengths and opportunities in the community for each of the 4 potential health priorities that we presented. And then we conducted a community survey administered both electronically and on paper to gather input from community members to help prioritize which health topic we should address. Let's go to the next slide. So again, for selecting the top health priority, we looked at the local, state, and national health data and identified 4 areas of opportunity. And the areas were selected based on several criteria, including potential for positive impact on the community and feasibility to address with research. So, for example, if housing shortage was a significant issue and priority in the community, in comparison to other areas that could be important, but it might be a problem that's hard to address with clinical or translational research. So we try to balance feasibility with impact. You can go to the next slide. So the topics that emerged for initial consideration, one was a topic called deaths of despair, which is a combined measure that the CDC was using at the time that combines deaths related to alcohol use, substance use, and suicide, and kind of combines all deaths related to any one of those problems or multiple of those problems. And then rates of obesity and lifestyle or healthy behaviors, healthcare access, and cancer screening. Go to the next slide. So at our event, we had 13 community leaders in attendance, including representatives from the Economic Development Association and the Chamber of Commerce, multiple people from the local hospital and health system, including community health workers, registered nurses, providers, and clinic managers. We had representatives from home health and hospice, from the state food bank, and the local school district. And go to the next slide. So these are the questions that we posed to the group. We asked, what challenges are there in the community to solving or addressing this health priority? What resources or connections are there that could help solve or address this health priority? What solutions or approaches have been successful in the past? And what solutions or approaches do you think would be successful in the future? So we really tried to approach this from an assets-based perspective, where we're bringing some curiosity to the community and to the conversation, and helping elicit from them what their strengths and resources are, in addition to what some of the challenges they're experiencing are. Go to the next slide. So far and away in the forum, healthcare access emerged as the major health priority that was needing to be addressed. And some of the challenges related to healthcare access that emerged from the conversations were difficulty recruiting and retaining providers in primary care, some state-specific licensing requirements that were new, and education requirements that were keeping people locally out of the allied health professional workforce, and then very limited access to specialty care and long waits and long travel times. So a patient who has to drive 3 hours each way for a 10-minute visit with their cardiologist is an example of that. Some of the opportunities, they had developed some successful partnerships with local and regional training programs to provide training opportunities for students and learners. They'd set up telehealth more robustly during COVID-19, the pandemic, initially for specialty visits. And what they did is had their primary care clinics build infrastructure for patients who didn't have broadband access to come to the clinic, and then do telehealth to specialty care outside of the community. They also partnered with local libraries to set up telehealth visit space. So they were really creative in thinking about how to overcome some of the challenges that are inherent in rural communities. And they also had a really strong visiting nurse network, and that team was really interested in thinking about how they could better support healthcare access and connection to the healthcare system, and involvement in early intervention and prevention. Next slide. Like I said before, we also did a community survey because we knew that we hadn't reached kind of all types of people in the community through the forum. And so we administered this electronically and on paper over a 1-month period, we had 138 respondents, and you can see the characteristics of the respondents on the left-hand side. On this survey, 94% of respondents rated healthcare access as either very important or important challenge in their community. And you can see a comment that someone put on their survey, reflecting on the importance of healthcare access and challenges with healthcare staffing and access to specialty care. So lots of significant challenges in healthcare access. I'll go to the next slide. So that sort of wrapped up the community needs assessment that we did with the team in North Central Idaho, and we're now currently underway in helping them develop and test some solutions to improve healthcare access in areas that are important to them. So we'll be able to report in the future on the success of that. The last piece I'm going to talk about briefly here is an example of a WPRN study focused on improving the quality of care of older adults in primary care. And I thought this was a really good example of a study to share, because this is an example of a study that was designed as an engagement project, which is a type of project that we launch often at our annual meeting, and we really lean on our champions and our clinic representatives to help us select a topic and design a study that can be accomplished by a large number of practices in a relatively short period of time, and addresses an important topic for primary care. So this is a study that emerged from that process a few years ago, and it was in partnership with the Northwest Geriatrics Workforce Enhancement Center, which is a center based here at the University of Washington that provides training and education to primary care team members all over the region to improve care for older adults. So we wanted to kind of bring together a QI training piece as well as a monitoring piece. Go to the next slide. So in partnership with a group of champions who are really interested in this topic in the Northwest GWEC Center, we selected multiple quality measures for older adults, including documentation of advanced care plan, documentation of dementia education and support of caregivers for patients with dementia, evaluation or interview for risk of opioid misuse, falls risk assessment, and use of high-risk medications. So the WPRN team developed procedures to help support primary care practices, primary care clinics, collecting and reporting at least 1 and up to 5 of these measures. And these measures actually came from a Medicare MIPS database, which is a type of reporting that a lot of primary care practices do. Go to the next slide. So we asked that practices be willing to collect the data annually, and again, they could select 1 or multiple measures that they wanted to report on. And we provided all the tools they needed to do that reporting, and then they shared their reporting outcomes with us. And then we also helped connect them to educational offerings from Northwest GWEC so that they could make improvement in areas related to their quality that they were interested in focusing on. Go to the next slide. So in the first year of this project, we had 4 clinics that participated. 2 of those were connected to a residency program and actually involved residents. So residents got a chance to be part of this and contribute to the scholarship of it. And then we added an additional clinic in the subsequent year. And you can see this is just some of the preliminary data in terms of the quality outcomes that practices were reporting. So the range of patients that had an advanced care plan documented in the participating clinics was between 8 and 35% at baseline. So I'll turn it over to Sebastian now to talk about loneliness.
Sure, and this is like one final example of another type of research study that we do in the WPRN, and it kind of ties together some of what was identified in the Rural Health Initiative with like deaths of despair and looking at loneliness and kind of isolation, and some of the opportunities for integrating behavioral health that we've talked about in our network. So this study was focusing, kind of emerged as a topic from clinician interest and from a lot of interest from nationally from the U.S. Surgeon General. The previous U.S. Surgeon General really put a light on loneliness and the impact on health. He compared kind of loneliness and the impact on premature mortality to smoking cigarettes and said being lonely, like chronically, is equivalent to, in terms of premature mortality risk, smoking 15 cigarettes a day, which we talk a lot in primary care about helping people quit smoking, right? We spend, I think, for most of us, less time talking about like your relationships and your isolation status. And then he also showcased evidence suggesting the relationship between loneliness and other mental health issues like depression, anxiety, but also like its relationship to cardiovascular health, diabetes, and other common things that we see in the context of primary care. So we did a pilot study where we surveyed within one health system. We got from the EHR data contact information from everyone age 18 to 25, and we focused on 18 to 25 because the previous survey had shown that the young adult group was actually the highest risk for loneliness. And a lot of the research previously had focused on older adults, and no one had really done a lot of work looking at young adults before. And there's actually limited research funding for young adults out there. So we focused on young adults 18 to 25, and we pulled data for anyone who had had a primary care visit within the past year. And we texted young adults with an invitation to participate in the survey that included some demographic information and also there's a 3-item screener for loneliness. So it's easily screened for because it's comparable to like a PHQ-2 or a GAD-3, right? For those who consented to like those who screened positive for loneliness, we then asked them if they wanted to participate in a study, and we randomized them to either a CBT intervention or to a social navigation intervention where people were in a group and actually got to make plans and were kind of navigated into making social connections. So as I mentioned, the social navigation group was really a chance to map out social networks to make future plans. It's modeled from a UK intervention called social prescribing, where someone is connected with a link worker who helps them with social needs that could include loneliness, but it could also include like food insecurity and could include housing, transportation. So it's a model kind of like a community health worker model that we could kind of further implement in the United States. And especially in Washington State, where we will start paying for community health workers and Medicaid as of July, that's a huge opportunity to test and implement these models. CBT, I think most of us know what CBT is. It was specifically a CBT intervention that was developed for young adults in Sweden. So we modeled that and took it for young adults as well. And we did both of these interventions in group settings. So one of the interesting things that we found that was unexpected, because we administered PHQ-9s on everyone who participated in the groups, was the high rate of kind of suicidality. And I think there's actually an interesting Venn diagram between I feel alone, I'm a burden, and the capacity thoughts or suicidal thoughts. So actually of the 20 people who participated in groups, 40% reported baselines, like some positivity on the 9th question of the PHQ-9, which asked about suicidal thoughts or ideation. So that was an unexpected finding. And obviously we didn't have findings to look at statistically whether that decreased, right? Because we only had a pilot group of 20 people, but like at least kind of looking at the trends, that suicidality decreased after people participated in the group. But that is like showcasing just like the vulnerability of this young adult population who may be lonely, but also like are at high risk for suicidality as well. So from our baseline demographic survey, 243 people in this health system responded and said, yes, I'll participate in the survey. And we found that about half of them were screened positive for loneliness. The UCLA loneliness scale has 3 questions, scored 1 to 3. So you can score between 3 and 9 in total score, and anything 6 and above is considered lonely. So the things that were associated with loneliness was being single was associated with being lonely, which isn't a huge surprise. But the other thing was gender identity and sexual identity were associated with loneliness. So people who were non-binary or female were more likely to be lonely. And then what we also found is anyone who identified anywhere in the sexual gender minority had the highest odds of being lonely. So I think it was like more than 2.5 times the likelihood of the general population of young adults, which already has a high rate of loneliness, right? So it's like even higher risk than the usual. So we found decreases across the board in participating in our CBT and social navigation group. And more importantly, I think as a pilot study, one of the benefits of doing a study within the PBRN is we can talk to people and interview people. So we interviewed some of the participants who participated in our study, and we found, yes, they really enjoyed participating in the CBT and social navigation group, and really liked the consistent and proactive nature of helping people make social connections. I think there was we asked for like adaptations and improvement opportunities. The CBT side said there were too many worksheets and too much homework. It reminded them of school, right? Like for young adults. And the social navigation side said, actually, we did these groups virtually. So like they wanted to actually do them in person, right? Instead of actually virtually. So it's interesting to hear young adults talk about wanting to be in person, because I think a lot of the interactions in social media in the world are virtual in nature. So it was interesting to see that. And then there was a preference for a larger cohort and suggestions for more than 5 sessions of groups. So we found that in this case that recruitment processes, interventions are feasible within one health system. We hope to expand them to more than one health system in the PBRN. And we have preliminary results to hopefully build to a larger study. We're excited to potentially look at how we can explore different outcomes by attendance, by engagement rates. And our goal here, based on our findings from the survey and informed by our pilot findings, is to focus on the sexual gender minority population and apply for future grants in that population. Although given the current climate, that may pivot to something more pragmatic and with a semi-focus on that population. And we are developing partnerships with community organizations that specifically focus on the LGBTQIA population. Other things around loneliness that are happening, there is still a huge focus on the older adult population. And I think there's interest in how can we address people who are lonely and as an older adult, who are widowed, who are maybe have lost friends to death, or to changing circumstances. And then also we're doing a pilot looking at loneliness for those who have chronic pain on chronic opioids, because often in that population, the pain prohibits people from engaging in activities that they want to be engaging in. And how does that differ across our PBRN as well? So I think Allison's going to talk a bit about some of the student opportunities that we engage in.
Great, thank you. All right, so I'm going to wrap us up with just a little bit of talk about our interaction with the WWAMI Medical School students. I think hopefully all of you know about the WWAMI program and its goals, but it's really focused on increasing the number of primary care physicians, particularly in under-resourced areas, and offers a lot of opportunities for community-based medical education. You can go to the next slide. So students in the WWAMI programs have 2 different opportunities in the summer between their first and second year. They can pursue a more traditional research opportunity called the Independent Investigative Inquiry, or III. And in this case, they typically partner with a faculty member and do a kind of a more primary data collection discovery oriented project. They can do something called Scholarship of Integration, which is where they do more evidence synthesis and review. And then the Rural Underserved Opportunities Program is a more community-based clinical program that I'll talk about in a minute. So RUOP, and I think there's folks on the phone who are a lot more involved and familiar with RUOP than I am, but it's a program where students spend 4 weeks in a primary care clinical site, really immersed in the clinical setting and in the community. And they can be located all over the WWAMI region, so it doesn't have to just be in Seattle. But one of the outcomes of the RUOP experience is some kind of health education or community health intervention deliverable. So they have to do some assessment of community needs and then design or plan to design something, a tool or resource to address those those community needs. And over the last year or two, we've really been exploring how we can potentially leverage some of that experience and work into practice-based research. And I think really have been recognizing that the medical students, especially ones that are outside of Seattle, may not get access to research opportunities in the same way that the Seattle students do. And all the medical students are hungry for research opportunities that incorporate primary care clinical practice. And so we're really excited about the ways in which the WPRN can partner with the medical student programs to enhance their education and research experience, but also to help prepare them to be clinicians in practice who might be part of a PBRN or leading QI work at their own site. Go to the last slide is just a call to action. If you like filling out surveys or are interested in sharing your opinions and perspectives on primary care with investigators, we'd love to have you join our provider panel for research. And the link to sign up or the QR code are up there, and we'll share it by email afterwards too. But you will, if you join, you get up to 5 requests a year to complete a short, like 10-question survey, or consider participating in an interview, and compensation is offered for most of the things that you might participate in, and we do review of all potential requests before they go out to make sure they're a good fit. And you can always decline or delete or ignore any invitation that doesn't strike your fancy or that you don't have time to look at, and you can quit at any time. So please consider joining us as you're able. And I think that's the end. So I think we're happy to take questions or comments or hear thoughts. Thanks for your time today, and look forward to hearing the discussion.
Thank you so much, Dr. Tong and Dr. Cole. Thank you for that talk. That was great. We don't see any questions in the chat, so please feel free to submit those if you'd like, but we do have a question in the room, and I'll pass the mic on.
Hi, thank you for your talk. I'm Majorek. I've met y'all before. When I think that the network is really awesome, and I've thought about it a lot, and thought about potential research projects that would work well in that setting. And something that comes to mind over and over again for me is that some of the attributes of primary care that we think are really important are two important ones that we might want to study are longitudinal relationships and sort of quarterbacking care that crosses settings, right? And I'm wondering to what extent the network has been able to support projects where you're actually able to track individuals across settings, because their health insurance changes, so that where they were getting their primary care, in one point in time is not where they're getting their primary care at a later point in time. And like, are you able to link individuals across different electronic health records where all of those different systems are in the network, but they're not the same healthcare system? And likewise, if you wanted to look at, is what we're doing in primary care impacting the likelihood that someone winds up in that secondary care, emergency care, et cetera, or what their outcomes are when they get there, or when they're discharged from those levels of care and go back to their primary care? How are they are they cared for in follow-up? Have you been able to, or have you seen any projects that have been able to trace people from their primary care into those other systems and out again in their records or in something like that?
I think that's a great question. I think one of the challenges of doing kind of broad system level questions is the NIH has just historically been so disease specific. So for those of you who don't know, there are 27 institutes and centers that fund research individually, and a lot of them are focused on specific organ systems or disease processes. And I think, yes, they'd be interested in doing that from an institute, like about a specific disease process, or like, for example, like over cancer care, or for example, over like cardiovascular health. But like across the spectrum in primary care, I think that's harder to find an institute to be home for that. And that is partially where this Care for Health initiative that we were fortunate enough to be awarded comes in, because it's supposed to transcend the institute's look at cross-institute kind of collaboration. So some of those answers and questions can happen. I think some of the challenges, the data interoperability and accessibility is the big question, but I think we would be open to questions in research projects like that. I think there's been an attempt through DataQuest at ITHS and kind of in conjunction to do some of the data interoperability, but I think we need to work and grow that arm of research and kind of that arm of questioning to be able to answer questions like that. And that was something that when I heard Dr. Bardignoli talk in December at our intro kickoff meeting for Care for Health, that was one of the things she highlighted was like, we need to be able to answer things with data. So that's definitely, I think, hopefully still of interest at the NIH level to like be able to facilitate those type of research questions.
Great. I'm curious, excuse me.
I was going to let you go first. Hi, this is Carrie Stevens. You guys, what an awesome update on so many cool things that you all are working on. I just am really curious to hear off the top of your heads of what you're the most excited about on the horizon of next steps. You know, whether it's the care direction, loneliness, Allison, all the things you're doing in rural, et cetera, that are just kind of top of mind given everything happening right now. Where are you guys most sort of excited to see things go forward?
You want to go ahead, Allison?
Sure. I mean, I think it's hard. There's so much that's really been fun and exciting and interesting. I think if I had to pick one thing, I would pick the Care for Health initiative and this opportunity to really dedicate resources and staff and energy to engaging with our practices and really understanding what their priorities are and how they think about collaboration and research and what makes it meaningful and impactful for them. So I think it's a real luxury to have the opportunity to do that, and it really is going to lay the foundation for decades of work in the future. So even if the Care for Health initiative isn't sustained, federally funded in the way that it was intended, I think it has offered us such an exciting opportunity to do work that otherwise we just couldn't do. That's what I'm most excited about.
I would echo what Allison's saying, and I think one of the most exciting things that's emerging from kind of research priorities and excitement from our clinics is what I'm most excited about. And I think that's improving processes for care and finding how we can better do team-based care to address especially care that needs to take place outside of our clinic walls. How do we navigate patients into better taking care of the health risks and preventing disease-specific processes? So I think that kind of process and finding like the navigation system for that, if we can develop research questions that help systems implement that to actually improve the patient experience, not just in the clinic walls, but in their lives, I think is what I'm most excited about.
Yeah, and I was curious, in a clinic setting, how you integrate these kind of inquiries into our work, and how do you create communications between these research networks and primary care settings. I see, I saw the QR code and that's a great way to do surveys, but just interested in how that dialogue happens. And then furthermore, how do you share those results? Because the studies you presented are very relevant to the work we do and very interesting answers to questions that would be relevant to primary care.
Yeah, I think the way our network works is that for each practice, there's usually a practice champion who's part of our network and receives email kind of on a regular basis on things and opportunities. I think it's a growing kind of emerging thing on how we best share results back to the community. Like historically, the academic community has done like academic presentations and manuscripts, right? So like, are there ways to reach out to practices in the communities and like shorter one-page briefs and website announcements and some things like presentations at CME events, I think. So I think we're trying to broaden the horizon to think more about those opportunities as well.
Thank you so much, Sebastian and Allison. The opportunities just seem enormous. If you could, when you began, Sebastian, I think you started with pragmatic clinical trial and some different opportunities. What do you see as the new methodologies, research methodologies, or opportunities to better study some of the challenges? And I'll use May's question as an example. She's asking about continuity. When we have the interoperability problems and those sorts of things, one of the questions is, do we center our investigations, for example, on a clinical practice? Do we center our investigations at the patient level? Do we center them at the provider level? When you're thinking about your research studies and you're identifying the methods, and short of just saying, well, it's a multi-method study, what do you see as the future of how we in family medicine can maybe own a research methodology that begins to answer some of these questions that could solidify maybe our Institute of Primary Care at NIH?
Yeah, thanks, Paul. Thanks, Paul, for that. Simple question. I think moving beyond the traditional RCT that we have is really important, because like often like the historical RCT that's done at NIH, like they have exclusion criteria for anyone who has multimorbidity, right? Like they have exclusion criteria. You have to show up at a research center. It's in a controlled environment. Like the results aren't generalizable to the patients we see who are complex, who have social needs, who have multiple chronic conditions, and who may not be fully compliant to the interventions we're doing, right? So like, I think to study things in a real world setting, part of it is what we're calling the pragmatic clinical trial, where we're doing a nudge or an intervention in a primary care setting and teaching someone in that setting to do that intervention. And then we're seeing what happens in real life, right? Like in the real world setting, and not controlling for all those factors. I think part of that is maybe what we're doing in primary care. And then I think the flexibility around that to let like who the interventionalist is may vary based on the clinic, right? Like who the patients are and how complex they are. Like different clinics have different complexity of patients, right? So we're measuring that, but we're not like excluding people from those studies, I think, so that when we get the results, they're applicable to primary care. I don't know, Allison, if you have anything to add.
Yeah, I think it's a great question, Paul. And I think I understand your question, and maybe a call to action to say, like, as primary care researchers, we're not just accountable for answering critical questions, but we should really be pushing and innovating in our methodology too, because of the expertise that we have in the environments in which we work. We're the right people to be doing that, which I think is true and a very exciting way to think about it. I would say that even beyond moving past a RCT, and I think there's so many innovations in evaluation that can be learned from quality improvement that could be applied to research, and thinking about the clinic or the health system as the unit of analysis and the unit of intervention, because that's how it works in the real world, right? Clinics either decide to do something or they don't, and so that's probably how we need to be studying interventions and outcomes. And I think N of 1 trials could be another exciting area to really look at innovation that's happening on the ground and applying a more rigorous evaluation lens to it. So I think there's a huge spectrum of what could be done, and I think bringing a rigorous approach to evaluation, but not be holding ourselves to the traditional clinical trials definitions is a really exciting opportunity.
I loved your answers, and what you've shared is the challenge of heterogeneity And heterogeneity requires inclusion of all members of the community. And I think you're just right on target. And ultimately, this gets to the challenge not of internal validity, but external validity and generalizability. And oh, that I think is where we can make our mark. I loved your answer. Thank you.
Thanks, Paul.
All right, well, we're right at time. Thank you all so much for attending and to our speakers. And I want to encourage you to submit your evaluations. There's a link in the chat and also posted here. And please plan to join us March 12th with Dr. Claire Simon talking about the role of primary care in the evolving opioid crisis. So thank you all so much.